In the case where we have a very healthy patient manifest a possible problem or in the early stages of a possible problem,
Yep.
the average problem for average Americans is going to be a heart attack first, cancer second, and then every other. And every other, we don't have to talk about that because we have to focus on these two things. And unfortunately, I have to call it as I worry. So even if we just have a slight prostate elevation, it's a bump.
Yep.
But that has to be, I have to be truthful with you that if we're going to architect a change in life, and you're one of my healthy guys, obviously, one of the boring guys, to architect a change in life in somebody who has a great lifestyle already and or data that shows no disease coming,
Yep.
it's going to be tough. And that's why I prefaced our visit today with be open-minded.
Yep.
And I have no allegiance to any companies or nutritional practices, but to cut to the chase, and you probably know already where I'm going, the data with prostate cancer, there's going to be information out there that's very confusing. And you can, as we talked about earlier, you can cherry pick the data to match what you want.
Yeah, right.
But I have to be the neutral party / coach, and I have to tell you, I'm, again, no allegiance, but if I have to attack prostate cancer, the only data that I've seen that's convincing is small data by a small subset of patients by Dean Ornish. And my athletes don't like Dean Ornish. Well, most of my athletes don't like vegan low fat, and that's what it comes down to. You took a deep sigh there.
I actually don't mind it.
Vegan low fat. Okay.
Yeah, because I mean, if I could do unsaturated fat, it's still fat, right?
It is.
And I don't.
Well, yes, but you're not supposed to have even that.
Oh, okay. Even to a certain degree, avocado.
Well,
I know
think
he's more vegan than he is.
Let's just call it as it is, less than 10% fat.
Got
Period. Definitely not saturated.
But on the lipid stuff, it should help there too, right?
It should. So
I know we're jumping all over. Sorry.
No, exactly. So the average patient, again, you're well read. The average patient would be bouncing back and forth, thinking, "Well, I want this, but I don't want that.
Yeah.
If I do this, will it screw up my?" But the data from Ornish, and again, his subset of studies is small, but difficult to ignore. The data that he used to furnish the positive results in prostate cancer in situ, the reversal of prostate cancer in situ, which, again, you're not that, but the data was the same data that he used to reverse heart disease.
Yeah.
So like 15 years ago when he was Clinton's doc, as Clinton was in presidency, he came up with that information, and because of the small subset, but the powerful levers that he had to pull, or that he was associated with, he got that diet to be approved by Medicare, which is a really tough feat because Medicare doesn't approve anything. But when they approve a diet, and that usually means, I think they call it the intensive lifestyle reversal program, when they approve a diet for people that have elevated lipids and or high risk for a heart attack, that's unusual. They'll approve medicines. They won't even approve all medicines.
Yeah,
but when they approve a diet and they pay for nutrition, because they don't pay for nutrition for cholesterol, they don't pay for nutrition for obesity, they pay for nutrition if you're a declared diabetic, but when they approve that, that's awesome. So anyway, the same data sets, even with the same information applied to telomere length, the DNA caps, all the positive results. But here's the thing, my critique is that nobody else has had the connections that he's had or the length of time that he's had.
Yep.
There are data subsets that are coming out that are showing the opposite. Low carbohydrate living does produce the same thing as far as the hypothesis of improved heart outcomes. And I'm just waiting for that data to be extrapolated to low cancer risk. And two different subsets have shown, in the case of glioblastoma multiforme, which is even worse than prostate cancer, if you implement a low-carb diet, that was the studies of Dominic D'Agostino in University of Southern Florida, there's a bit of a significant, I don't know if it's statistically significant, but a significant increase in the outcomes. And glioblastoma, if you do the nastiest chemotherapy and surgeries, 3 months extra. But they seem to get this. I think this data set showed a year extra to 2 years extra.
What's considered low carb? How many grams?
10 grams. Well, just the opposite. Think of it this way: when Dean Ornish says 10% is allowed as far as fat, which is 20 grams, I think. That's probably, it depends on the total calories per day of the person. The same with a low carbohydrate. I think D'Agostino was using a base of, for some reason, 20 grams of carbohydrate sticks in my mind. I don't remember if that's the Atkins project or not.
That's pretty low. But then you're on a high fat.
You're on a high fat diet. Yeah, so I think the easy way for me to remember, because my favorite scientist, PhD, Chris Gardner, he always chooses easy things for the public to remember. And he did studies where he lowered to 20 grams of fat or 20 grams of carb. Yeah. And he compared the outcomes. And the outcomes are the same. 12 months, people that got kicked off or couldn't maintain, they were allowed to go between. I think his, since the A to Z study he did back like 15 years ago, he's still, and he's plant-based. Wow. And he's out of Stanford, but he still produced the same outcome. The same outcome is there could be metabolism, there could be genetic issues, but the most important thing that they're finding is a well-balanced diet, not for too long, and without restrictions, and has to taste good. That's the bottom line.
To maintain it.
Right. Because if say this is not you, and I'm dealing with somebody with prostate cancer, and I do have a couple patients with prostate cancer. Okay. If we make a change for, say we go Ornish, a low-fat and plant-based purely, which is vegan low-fat. Mm-hmm. And I have done that, and it was novel, but I did it knowing there's going to be an endpoint. So I maintained my 3 years thinking I'm going to get off this because I don't like it. How long can an average person maintain it? And usually it's about 6 months.
Wow.
The restriction, nobody likes restriction, that's just it. Everybody likes whole food. Yeah. But not all of us can cook whole food, and not all of us can afford a maid or a chef. Yeah, right. And or live with our parents, which is another old-fashioned way to do it. Huh. So again, what do we do with you? That's why I wanted to open this up to possibilities. I think there's ways to template change. Okay. But the question is, with somebody who is already very healthy, you have a healthy individual over here, so your exercise in the form of cycling is how many minutes a week, just so I can get a baseline?
Well, four at an hour, 4 sessions at an hour right now, and then 3 at an hour and 1 at an hour and a half.
So we got at least it's 5 times, yeah. 5 times 60. Yeah. 60 minutes times 5. So we're hitting it, and how good? So we hit. You got at least 150 minutes easy of exercise. Nutrition practice currently, if you haven't modified it yet.
Well, so it's between low fat and low carb. So let me back up a little bit. So from the lipid standpoint, the biggest concern you see is the particle size and count from an LDL perspective, or is
yes.
Okay, like ApoB and that test. I think what the latest one
80s.
Was. Okay. So
which is excellent.
Okay, so I was wondering, do I focus on getting that lower? I took red yeast rice 3 months ago and got down to 70. But the question is that healthy long term to be taking it?
I'll go ahead and answer that.
Okay.
I do think it's healthy.
Okay, so the only other time I've done the particle size, and this is your question about my diet today, but the only other time I've done particle size, and when I think I mentioned to you in the email back, was I knew that was a concern. I went and took a look at those results compared to this time, because I've only done it twice in my life, this time and in 15, so 8 years ago. 8 years ago, I was that's when I started investigating keto. I started doing more keto-based. However, my intensity in cycling is the highest it's ever been.
Now or before?
Then.
Would you attribute the intensity as being that you got the fuel source, or you were just exercising because you had a goal and the fuel source came along with you?
I had a goal, but at the same time, I didn't really know enough to say, based on what I was putting out from like zone 4 and 5 consistently, I shouldn't be on a keto diet. So what happened was, if I compare my particle size then to now I've done aggressive since then, but I haven't had that full particle size test between then and now.
So back then, 2015, great FTPs?
Yep.
And best you've been ever?
Well, from a performance standpoint, not necessarily, because I was also doing keto, which now I find is like not sustainable to be. I think I was hitting, like if you look at my hormones, they were off at that time because I was totally overtrained relative to my diet, I think.
Perhaps. Did you do keto and aggressively lower your calories per day?
Yes. Okay. So that's another thing I want to bring up. I think at the same time I was told by the doctor that, dude, you got to, I don't recall my intake, but my calories were so low. So I'll give you, like, for example, my cholesterol at that time. My cholesterol, LDL, at that time was 88.
That's pretty good. LDL-C of 88 during ketosis, or what you thought was keto, and an increase in your functional threshold FTP, and just a seat of your pants best I've been, or close to best I've been. That's something that has to account for it, even though something of overtraining might have inflamed you a bit.
Yeah.
But still, if that was a temporary thing, how long did you manifest the keto/performance?
4 months.
Oh, okay.
Yeah.
What knocked you off? Just curious, what knocked you off?
Part of it was like the test. So here's the downside. My A1C was at 5.7.
It's still not bad.
But I think relative to, I mean, after that, it went down completely because I think you tell me, because I wasn't doing enough carbs relative to the output, is that why my A1C would have gone up? I mean, the source had to come from somewhere. Right?
Let's just think about that. So hemoglobin A1C tells you what your average glucoses were over the course of 3 months. And you can interpret it two different ways. You can interpret, so if 5.7 is average, and that's pre-diabetes, that's the beginning of pre-diabetes. Pre-diabetes is 5.7 to 6.4.
Yeah.
After 6.4, you're diabetic. So you could have been here, 100, let's just say 180, 5.7. You could have also been, if you think about it, 240.
Yeah, right.
So it's hard to tell. It just gives you an average. So what bumped you into 5.7? It depends. That really shouldn't be. If you were truly ketosis, keto is all fat and all fat burning.
I was extremely low carb.
Did you check keto levels?
No,
ketones?
never did. I just know my diet. Well, I think it was a combination of 3 things. Way lower carb than I was used to. Way more training than I was used to. I was probably exhausted. And I think calorie count was overall too low.
So back to your question, did you overtrain? What caused the 5.7? Unfortunately, our data is limited because we should have checked beta-hydroxybutyrate to see if you were in ketosis, because even if you're low carbohydrate, some people can maintain that for 4 months and still not click your beta-hydroxybutyrate to start digesting fat. You'll just be not digesting fat, not recognizing fat, not having any carbohydrates, and then overtraining. That's inflammation.
And overall too low a calorie.
And lower calories, so low fuel.
I mean, I was like 182 pounds.
What's your good fighting weight now?
I mean, I feel great at 194.
182.
So from a power to weight ratio, it was great, but
but
I mean, I was
wasn't
probably losing muscle.
So just to also take it off of that, because some folks might be interested in how you did it and what you did.
Yeah.
If you're an average cyclist and you're doing that kind of stuff, you've made the designated amount of activities per week as far as minutes, and you're maintaining a pretty decent. Well, you're not low carb anymore, right?
No, lower carb. I'm trying to time my carbs relative to the output.
Okay, so kind of almost like backloading for performance.
Yeah, exactly.
Okay.
I don't know if there's any benefit of that. I mean,
well, again, in theory, the cyclists are the ones that do the most data. You guys are crunchers. And Inigo San Milan out of University of Colorado really pushes the paradigm as far as getting grants to pay for measurements. And he's the guy who popularized Zone 2 and Zone 5 for everybody, not just cyclists.
Yeah.
But I guess the 30,000 foot view is, as long as you have fuel that's accessible, who cares if it's low carb? Who cares if it's low fat? Who cares if it varies? Flexitarian diet, according to, I forgot his name, a PhD. But you use your fuel for what you're doing, and if it fuels an exercise routine, then the exercise routine, especially if it's novel and you're involved and you're really committed, I think any fuel system is good. The question is, are we trying to exercise and feed the exercise to use that as the biggest lever for prostate? Let's just call it prostate cancer. I don't think you have cancer, but if we have to put you into a rut and we have to be committed into saying, okay, if we have potential for prostate cancer, just dive into what's been proven with prostate cancer survivors. And again, the data is limited, but I think Dean Ornish has the greatest girth of knowledge and or experience. But again, you didn't tolerate your version of keto. Did you have a nutritionist that backed you up?
No.
You're very well read, but you did not tolerate keto past 4 months. You probably could have continued, but I think from what I hear, your 4 months was stopped because of the data.
Yeah.
Was it, if you didn't have the data, you think you would have been able to continue that?
Yeah.
Even though you're telling me you were overtraining, you weren't hitting symptoms?
Well, I maybe would have cut back on the training, not the diet.
Okay, okay. So if we didn't get the data, and you wouldn't have been discouraged, because it's disheartening to say, oh man, 5.7, that sucks.
Exactly.
So if it took the wind out of your sails, if we didn't do that, then you might have been still doing it. And I would postulate for you that if you allowed the low carb type living to percolate, you would have seen the numbers change. I think there is a little bit of a bump up when people...
Oh, then an adaptation?
Yeah. There's a little bit of a bump up, especially when you're finding your way with fat. True low carb is 80% fat.
Yeah.
But that takes some getting used to, and we have to talk about your gut. I don't know about your gut, but I will put a question mark on the gut.
I've never had issue in gut.
Oh, so gut's okay.
Yeah.
So
but now we're leaning into, okay, higher fat is okay, but if we go back to the prostate issue,
if we're following Dean Ornish, but that's just a potential. We're not there yet. We're still building your case here.
Okay.
So you tolerated that. You bumped up your 5.7, your A1C. I postulate is, and you brought down your LDL. That was back then without red yeast rice.
Oh yeah, for sure. So here's where I started, the particle size, which is the thing that kind of stands out today. I know I'm pattern B, which will never change, or A, which will never change.
Yeah.
So if you look at my particle number, LDL today, the latest was 1801, which is freaking way high relative to the quote unquote norm. In 15, it was 1,000.
LDLP 1,000. It almost doubled between 15. But you're also committed to, let's see, LDL particle count in 15 at the same time that you got the A1C at 5.7.
Yep.
That's interesting.
So if you look at my LDL small, which is 269 today, right? Back then it was 160.
269 LDL small, 160.
If you look at my medium, it's 358 today. Back then it was 200.
Okay.
And then if you look at my large, which is, it was red then, you want it greater than 6,700. Today it's 6,200 or 3.
Okay.
Back then it was 5,300. So it's the opposite, which is, it was worse then.
All right. Just for folks that might be watching, I'm going to just take this off because it gets confusing.
Yeah.
So the particle size, particle count is important to give you a vast swath to say, hey, you got way too many of these. And within that LDL particle count, you have small, medium, and large. And the theory is that the larger the LDL particle, the harder it is to get between the crevices. Harder it is to get between the crevices and embed itself in the intima to cause what everybody thinks is oxidation in the lining and a plaque. but that kind of gets confusing. That's why I just look at the more generalized view of what's the total particle count.
Yeah.
And again, we're throwing darts, we're making changes, and we're throwing darts again. So we don't have to get too detailed, although analysts, what do you do for work?
Sales.
Analysts love to do detailed stuff. Sales, I don't think, that's a big thing.
I do, but it's not relative to my profession.
Okay, well, I think for your cycling, most of my cyclists like to see numbers.
Totally.
Yeah,
Totally.
because you want to see that your performance and your investment is paying off,
Yeah.
not only see the pants look. So anyway, I would say that to me is a win as far as performance. So your keto attempt performance was improved. We can't say anything about anything more than that per performance.
Yeah.
So that's great. As far as what you're doing now, because this is coming back high, prostate is inflamed or something is making the prostate hot. LDL particle count is hot. So what are you doing now that's making this potentially?
No frickin' idea.
No.
I
Just like
thought that
this.
was a question.
Not the cause and trigger, but what's your lifestyle looking like now?
Compared to then?
Yeah, compared to 2015. We're almost 9 years out.
Higher carb, more calories. Older.
You know as well as I that if you're an athlete, you don't look older.
I mean, older than when I was then.
Older time.
Yeah.
But are you feeling it subjectively? Are you feeling something achy or difficulty with something?
Nope.
Erection or?
No.
Okay. Thinking, mentation, pulling memory out?
No. If I were, again, putting myself back in 8 years ago, intuitively, no, nothing. I can't.
You're feeling pretty much the same.
The same.
And that's the beauty of exercise. I am the same way.
Yeah.
In fact, last year I felt better than I had in 20 years.
Wow.
But I was focused and invested.
Yeah.
And that's, as we talked about earlier, it's very tough to maintain that unless you have a drive or a motivation.
I got a motivation each time, right? It's just racing. So it almost is counterintuitive to some of the speculation that may cause issue with your prostate. Now, I've read a lot of things that said it doesn't.
You talking about the seat of the bike?
Yeah.
Well,
perineum maybe, but I don't have issue with that from noticeable.
So no numbness or tingling, pudendal nerve doesn't get irritated. I don't know if we ever talked about this, but yes, the skinny seats on a racing cycle. So do you race professionally or amateur?
Amateur. Yeah, so mountain bike and cyclocross. So mountain bike is in the summer, cyclocross is in the fall.
Just so we're all on the same page, including mountain biking, we know, trail. I didn't know that was competitive.
Yeah.
It is competitive?
Yeah.
As far as time or?
Group races. So
okay.
It's not timed, it's against a group.
Okay, and cyclocross, what kind of level of competition are you involved with there?
All amateur. It's all within both. So if you look at mountain bike, Wisconsin has an incredible series known nationwide, as the cyclocross Chicago has an incredible series.
Okay.
Known nationwide, one of the biggest.
You're competing with time on yourself, and you're also competing with others.
That's right.
Is that fair?
Yeah.
You're always trying to be best in placement, but you're also trying to beat your PR.
Exactly.
Okay, I like that. It keeps you engaged.
For sure.
If I don't know where we were going with that, but if you invest that much time, and that's a lot of time that you invest, more than the average American, you said you're now also more carb and more calories. So, as far as the higher carb, are you following a book, or are you following a percentage as far as carb?
A gut. Now, every once in a while, I'll use an app to track. Just say, okay, I've been doing this for the last week. What is that from a macro perspective?
Which app?
I forget what it is. It's one of the meal planning apps.
Does it give you a percentage that you're hitting?
Yeah, gives you a percent in total macro grams.
And when you do the higher carb, does that mean you're also doing lower fat?
Yeah, so protein is what I maintain.
Protein at what grams per day, or?
I couldn't even tell you off the top.
Or scoops, or are you just doing whole food?
Both.
So
I'll get it through meat, mainly chicken, and then I will do scoops, pea protein or whey.
So plant-based and animal-based.
Yeah, so at a sitting, part of the gut, I mean, I'll do 40 grams without issue.
So 40 grams in supplement or with whole food and
Yes,
powder?
whole food and powder.
40 grams at a time is pretty decent. How many meals do you have per day?
3.
So is that fair to say 120 grams of protein?
Yeah.
You always make every meal to include a certain amount of grams of protein?
I don't.
Protein-centric?
Yeah, I mean, the only time I measure it to know what the grams are is when I'm doing the scoop.
Okay, all right, right.
Yeah.
So it's a rough estimate. The scoop is, that's what's so nice, is you know, okay, 30,
Yeah.
or if it's P, 25, or
That's
if you go 1.5, you go 40. I think, honestly, there's variations as far as how much the gut can absorb at one point in time, but the fact of the matter is that you're eating 3 meals a day and you're being conscious of your protein count. At the same time, you're also overall increasing your carb hits, or are you just answering and pushing the carbs in on days that you aggressively work out?
I'm starting to do that more because, honestly, the latest result that came back on the particle count and size, I thought back immediately, God, the only time I had this was back when I went through all that other stuff, when I was lower carb. And I don't want to immediately assume, okay, I was lower carb and that's why my particle count was better.
Right.
But it leads me to believe is, am I taking in too many carbs?
It's a good deduction.
You know?
It's a good deduction, but to offset that, as far as your carb, again, the question is, are you manifesting too many carbs? Your insulin was 2.9, fantastic.
Yeah.
Hemoglobin A1C, 5.2
Right, so
this time.
I was going to say it's working accordingly compared to especially in 15.
Right. So, something is working. How long have we just got the blood test showing that insulin and that hemoglobin A1C? How long were you had you been implementing your nutrition change before that blood test?
You mean where I am now as far as protein and last year plus?
So you've been applying the nutrition practice currently for at least 12 months.
Yeah.
So the 12 months in resulting in this kind of blood test, that's spectacular. Whatever you're doing now, if it is low carb, wait a minute, it can't be low carb. You said you're pushing carbs.
Correct. That's the difference between now and 15, which is I have higher carbs than I did in 15.
I see.
And my A1C is lower.
Yeah. Okay, well, let's get a picture of that, because obviously knee-jerk reaction is that shouldn't be, right?
Yeah, but that's why I'm wondering, I don't remember the count, but intuitively, and also I recall back in doctor in 15, is like your calorie count is way too low. I mean, wouldn't that drive the overall cholesterol down, particle size, overall particles down too?
Depends. If you're dropping way too low for the amount of training, yes, then something's going to shake the tree to give bad fruit, because that eventually is going to be an overtraining formula, and that's not good. That's an injury coming.
Yeah,
I don't know
right.
if that would result in inflammation markers coming up. But you also have to, with that note, you also have to realize, although you're very meticulous with your nutrition practice and memory, a lot of us don't remember a lot of the non-incidentals between meals. So if you finish off a meal, so anyway, that has to be taken into account. Whatever you're doing now, we don't have to be that exact. I think you're exact enough that we can move in the right direction. If this is working for you with pushing carbs, and when you say you're concentrating on protein with 3 meals a day, and you're using increased carbs compared to 2015, is there an estimate on the percentage of carbs per day that your app is telling you, or you're shooting for, maybe, or grams per day? You just rough estimating.
Less than 200.
Less than 200.
Yeah.
Tight. Okay, so increased carbs, but still less than 200 grams in a day.
Yeah.
That's pretty good. But if that's less than 200 and you're doing the protein, that makes sense. So that caloric balance, because that's low carb, but you are pushing a lot of protein. Protein can give you, as some arguers for low fat would say, or the vegan community, pushing too much protein can also trigger insulin, but it's not being triggered.
Yeah.
So your protein is very pure, and you've been doing it for a year. Your carb count is low. Are you intentionally putting more fat in?
Not intentionally, I think just it naturally happens.
Naturally.
Yeah.
What would be your total calories per day then, roughly?
I don't even look at that as much. I was
Okay.
thinking more.
Let's guesstimate though.
Yeah.
You're doing 3 meals a day.
Yeah,
Were you doing 3 meals a day back in 2015?
probably not. Well, 3 meals, but all smaller.
Okay, we're doing 3 meals a day now. How big is your plate? Standard size plate, 10 inches.
Yeah.
Do you fill it up with overflowing lettuce or?
Yeah, but I
swaps
could do
of
4 meals even. So I'll do like a smoothie sometimes in the morning. I'll do a pre-lunch, a lunch, and then a dinner.
Smoothie is, smoothies, the way I have seen smoothies, you can easily get in 200 to 300 calories extra.
I mean, I do like a cup and a half of blueberries, water, avocado, creatine, no calories there. And then just water. I use no anything else. It's all water.
So we have 3 meals a day and then a smoothie too, which we didn't take into account. How often per week do you do a smoothie?
Every day.
Do you do a smoothie as a substitute for a meal?
No, because no. Well, on occasion I will.
Oh wait, that's 3 meals and a smoothie. That's 4 meals a day. Do you do the smoothie as a dovetail to a meal?
Smoothie is always there. What's not always there is the meal before a lunch. So it's 3 minimum.
3 minimum.
Smoothie, lunch, dinner.
How often do you skip a pre-lunch meal per week?
Well, yeah, I'll probably only do the pre-lunch meal 3 days a week max.
So,
It depends if I'm working out or worked out the day before, and I'm like, oh
got
my
it.
God, I'm
So
dragging.
we're still 3 meals a day with
So if it's what, I don't
variable-
know, 3,000 calories?
Yeah, easily.
Yeah.
So it depends on what that pre-lunch meal size, because most breakfasts are.
It's made up of lettuce, hummus, beans, and perhaps some chicken.
Jeez, that's a snack and that's healthy. Usually that snack would be chips or some indulgent
I don't
food.
do any of that.
Nice.
Yeah,
So the highly processed grains are decreased with you.
Yeah.
Nice. And sugar is decreased, I'm sure.
Yeah, I don't. If I see any label that has more than 4 grams of sugar, I try not to eat it.
So as I mentioned, you are very meticulous with what you do, and to me, just the thinking is that you shouldn't have this. There shouldn't be that. But if we take the high road,
Yeah.
the high road would say, listen, we have a problem, and hopefully it'll reverse. I think it will reverse. But if you didn't manifest all this and your attention to detail, this would have been higher and or at an earlier age. If you think about it in the positive way, the high road.
Yeah.
You're now 50,
60 next month, or 59 next month.
59 next month. So you're old as compared to 30-year-old cyclists or gym rats.
Yeah.
But you're more fit than a 30-year-old gym rat. And you've negotiated and found your way, and you've templated what is probably best for you at 58. So I think you're finding what improves lifestyle with you. The question is, will it reverse this prostate? And again, to just go to the 30,000 foot view, the idea would be, what can we do to manifest anti-cancer, and in this case, anti-prostate cancer lifestyles? I don't think that the data, and please don't think of that as you. I just using generalizations to say what would be the best avenue for you to, for me and you to go through.
Yeah.
And I would default to say, well, the data is important for maybe entertaining the Ornish lifestyle. And I think, if I'm not mistaken, and tell me the truth, are you still practicing a lot of meditation?
Yeah.
So it was like an hour before or more?
Yeah, in the morning.
An hour of meditation in the morning, which is very difficult to
Well,
sit still.
so when I'm not riding my bike, I'll do that, because
Okay.
it's meditation to me on the bike.
I think it is. I think, well, depending on where you cycle, sometimes hitting
Never in
those
traffic.
intersections.
Yeah.
Yeah, right.
Yeah.
Intersections are mind-boggling high stress.
But even honestly, because I've done it so much, and it's kind of killer to get used to, but in a closed walled room in the middle of winter on a trainer is not the most enjoyable thing, but I do get into this meditative state. I've tried Zoom, or not Zoom, Zwift, right?
Yeah.
Can't stand it.
Oh.
So I look at a thing called Trainer Road. I don't know if you know it. So you put in a plan, and the plan will calculate your FTP over time, and then it'll designate plan. It's brilliant. It designate plans accordingly based on FTP and also what your goals are. So you plug in mountain bike race in May, July, 4 cyclocross races in which 2 are A races, and then it backs into what your plan should be, also based on your FTP. And then you stare at the screen, in which you have bars relative to doing intervals. That's meditative to me.
That is definitely gets you into a mindset. That's a different type of meditation than a
I don't think
monk.
of anything else.
Okay, that's fair. I think getting to the zone is very helpful. It's not serene, but it's helpful. Before I let that go.
Yeah.
The data that Herb Benson came out with in the 70s is that inflammatory markers decrease when you meditate and don't move. You work on breath and you take yourself into the part of the brain that does not need the frontal brain to turn on. When we are in exercise, it's a different form of meditation. I think I just did a hike and I was trying to get it in 30 minutes. That's not necessarily a nature therapy because I was counting down my time and I'm concentrating on this. But it cannot be discouraged that there is a benefit for being on a bike, on a treadmill, or on a trail. I don't use the bike. I don't use Zwift. Do you have resistance?
Yeah.
What do you have?
A kicker, Wahoo.
Kicker. Everybody's got the Wahoo kicker.
Yeah.
I wanted to get that for my cheapie, but that's like $1,000.
Yeah, it is.
But it is worth it. I think the
for sure.
and then you don't connect it to a screen where you watch something?
I do. So
Okay.
that's that trainer road. So it's
Got it.
it's a full screen. It gives you progress. All of a sudden, here's an interval coming. I guess it's similar in concept to Peloton. Difference with Peloton, it's a random tension as opposed to watts, right?
Right.
So the kicker is that ERG mode or erg mode that'll make you put out 220 watts or 300 watts at a time.
To match the road or course you're on.
Yeah.
There's something like that. Running doesn't have that yet, as far as I know. But there's Virtual Run that I like to follow.
Oh.
My patients are on a treadmill or at home, I tell them to get to Virtual Run. There's a guy that makes these, and there's videos of him walking through the mountain. It looks like he's using a GoPro. But it's kind of nice when you're on a treadmill because it's not so boring anymore.
Something to look at.
Right, exactly.
Yeah,
that's the thing that gives us the sustainability with the going indoors. But bottom line is that if you're able to manipulate this nutrition practice, I think I'd congratulate you that I wouldn't necessarily worry about this. This should drop. The question is if you've been doing this for at least 12 months and it resulted in an 1,800 particle count.
Is it genetic?
Theoretically, you're not. You're talking about familial hypercholesterolemia?
Or anything related. So my dad, he was on Lipitor forever. His
Everybody on Lipitor forever.
His cholesterol without statins was 300 plus.
Oh, okay.
And he died of dementia-related things that was vascular related.
Okay.
So I clearly don't have that.
Just to give folks the ideas, if we post this, an LDL or a total cholesterol of 300?
Total, but his LDL was out of whack too, as were his triglycerides.
Triglycerides are usually dietary.
Yeah. Okay.
Usually. There's some folks who are hypertriglyceridemia, and that lends itself to increasing LDL-C, but so there's even discontinuity in the definition of what is familial hypercholesterolemia. I think bottom line is if you have a history in the family of early death and or heart attack before the age of 50, your dad didn't, he just had an elevated number, and you have an LDL-C of 190 or more, and those are rough estimates, then that might set you up for the genetic. But there's several different genetics that present themselves. Bottom line is you're doing what you have to do to offset the gene. So it's either you suppress the gene or you bring out the gene.
Yep.
I think you're doing everything you're supposed to do. The question is, can we do anything better? And honestly, again, whatever we do here to take care of this, the cholesterol, LDL, your heart attack risk, should work the same way to decrease your prostate issues. And if so I was going to sell you or try to sell you onto vegan low fat. I'm not vegan low fat. I'm low carbohydrate. In fact, I vastly between low carbohydrate, 20 grams or less per day, and carnivore. It's just that carnivore is so much easier to just, I don't have to think, I'll just eat this and this, I'll make something.
Yeah.
But I wouldn't necessarily do that with you. I would just say whatever you're doing now, as long as we fine tune it, that should drop. And if we do have a positive diagnosis of prostate cancer in situ, we might just push it even harder.
Yep.
So I don't think the seat has anything to do with it. I do see some of the old data says that those small bicycle seats, as we were getting into, small bicycle seats, especially if you sit a lot on them, I don't think you sit a lot, but then it can increase the irritation to the prostate. But not every cyclist has prostate cancer or prostatitis. So let's move that part out. The fact that you're cycling, I think, will offset everything because you're putting so much into your metabolism. You're boosting of metabolism with exercise. And that testosterone is unbelievable. I have 30-year-olds that don't have testosterone like you. 800 is spectacular.
My free isn't out of control, though, right? Because
no. I mean, that's okay. As long as we have a high testosterone, the number, whether
you'd rather start there high.
Yes,
right?
yes. Whether you break it down into what you're free and what you're active, maybe your sexual hormone binding globulin is too strong. But bottom line is you still have the opportunity with a total testosterone like a 30-year-old, and you're going to be 59, 60 soon.
Yeah.
So something you're doing, which I think is the cycling, is paying off. Again, the question is, what is going on that's making this
Do you
the
think
issue?
that has anything to do with it? Testosterone?
What? Nah, the data...
Because DHT is that more so, right?
The data has been back and forth, but mostly back saying that no, the higher testosterons don't really... I know there are some people who believe that on a couple of studies saying higher testosterone potentially increases the chance for prostate cancer or cells that are sensitive to testosterone to grow. But I don't see that information is reproducible. I think it should be entertained.
Yeah.
But no, I don't think your testosterone's an ailment. I'm
not going to go out and try to lower it. So.
Yeah. And how would you lower it? You'd eat crappy food, you'd not get any sleep, and you'd stop exercising. So I think everything ailment you're doing is fine. So testosterone has a proxy marker, says that your lifestyle is great.
By the way, I'm sorry. Cortisol, I only turned my test in 5 days ago. It's not back yet. So.
Okay. So and the cortisol was the saliva.
Yep.
And it was in the morning.
Yep. I did it first thing before I brushed my teeth.
Or eat anything. Good, perfect. I think that's the best number. I used to do blood tests for cortisol, but I had so many variations. I used to do cortisol blood and DHEA blood. Oh. But the variations were not that great. And since I've been doing the free cortisols, although it's an extra trip for most of my folks, it's giving us good information on your quality of sleep. I'm assuming you measure your sleep, or
I don't.
Sleep stages.
I don't.
Do you? We'll get to that in a second. But
you were going to insulin. Sorry.
Yeah.
Cut you off.
Insulin sensitivity is perfect. But even then, with regards to cortisol, it still tells us we know your gonads are working properly. Mm-hmm. We know that your thyroid is okay. We will find out if your cortisol is being fed the sleep that it needs, because cortisol comes from adrenals. Adrenals can make testosterone. Adrenals usually make cortisol and DHEA, but adrenals are a direct extension of the brain. So if you're not sleeping, there's no way the adrenal is going to produce that much cortisol in the morning. So I'm hoping it's going to be 0.3 or higher. Okay. We'll see. Just so we have good argument, did you have a pretty decent night's sleep or a average night's sleep before you gave that sample?
Yeah.
Okay, perfect. And while we are talking about the topic of sleep, do you have continuous sleep or is it fragmented?
Well, the weird thing is with my prostate, the size it is based on the MRI, which is clearly larger than normal, I sleep through the night.
I always say that to my guys, that I really think if you work in an emergency room, you know some guys come in there with 1,000 cc's and they can't pee because they have obstructive uropathy. So we got to put I don't have to do that anymore, but I used to, as a resident, put a catheter in these guys past the prostate, allow this flood to come, but you have to clamp that off because if you let it drain too fast, they pass out. So you have to let a little bit of urine at a time. But bottom line is that, hey, if somebody can hold 1,000 cc's, average guy should be able to hold 500 cc's overnight, and 500 cc's is 2 Coke can bottles.
Wow.
I guess. So most of us that do have that to pee at night, it's not like you're putting out a whole Coke can bottle.
Yeah.
You're probably putting out a pint or half a Coke can. So why can't we hold that? I've always been under the impression that our fragmentation of sleep to pee is because the hypothalamus is not getting the dire rest it needs, and it's coming out of sleep.
Okay.
And because of worry, because of bills, because of I'm going to die
All
soon.
the above.
Yeah, whatever it is, I think that serves has a reason for the need to pee more so than a big prostate. So
Got it.
with your big prostate, you're sleeping straight.
Yep.
And are you intentionally limiting your evening fluids?
Yeah, I have been.
What time do you stop the fluids?
So, I mean, I eat super early. I mean, the latest I'll eat is 6, and that's late.
6 p.m.
Yeah.
What time do you
but,
sleep?
But I go to bed at 9 at the latest.
So you eat dinner, and then 3 hours later you go to bed.
Yeah.
And when is your last drink?
Try to make it like 7:30.
So 2 hours before sleep is your last drink. And is the last drink because you're taking your vitamins at night, or because you're thirsty?
I'll take like a magnesium.
So sip.
Yeah.
So less than a shot glass or 2 shot glasses?
Yeah.
That's not that much fluid. So bottom line is your biggest fluid intake stops at 6, 3 hours before you sleep.
Right.
Which is what I suggest to most of my patients. Stop 2 hours before you sleep.
Okay.
At least the gulps of fluid. And some people don't like that, but I still say it's the hypothalamus, it's not the prostate. But you've just proven that it's not the prostate.
Yeah.
So how big is the prostate on MRI?
86 cc's.
Okay, 86 cc's. And do we have a comparison?
No, that's
The first one.
yeah.
So we don't know how long it's been 86
Exactly.
cc's. For a 58-year-old going 59. We'll see what Doc downtown suggests. But if we have an enlarged prostate, if we have an elevated PSA, that knee-jerk reaction for me would be maybe it's a prostatitis.
Mm-hmm.
If it is a prostatitis, which I'm sure your previous urologist would have entertained, then usually it's use antibiotics for the prostatitis to see if we can reduce. Was that done already?
It was not. That's why I'm going to a different doctor.
Okay.
Part of that was discussed on that podcast I was talking about. And I had prostatitis, 20 years ago.
Okay, all right. So when we had a prostatitis 20 years ago, did we do, well, I didn't know you back then, but did you do a PSA?
No.
How did you know you had prostatitis 20 years ago?
I went to a doctor. And then the symptoms were way different. I could just feel like something was going on. And then they put me on Cipro, which there's no freaking way I want to go on that.
Cipro is an antibiotic that's typically used for prostatitis because it penetrates into the urogenital system very easily. But Cipro also causes tendon disruption, especially when combined with steroids. So, but you didn't have steroids, I hope.
No,
back then.
never in my life.
You just had the tendon disruption or the tendinosis, tendinitis.
I didn't even have that, but I just worry reading all that stuff about Cipro. Right?
Yeah. I think it's a healthy, it's an okay antibiotic. Actually, it's a good antibiotic, but yes, there are side effects we have to be careful of.
I'm sorry, the tough part for when I'm learning about prostatitis is it isn't necessarily caused by something that antibiotics would cure.
Correct. It's just that's the easiest lever to pull is it must be an infection. Especially with singles. So you're not a single, but that'd be it's probably a non-sexually transmitted disease.
Yeah.
Just a big prostate, elevated PSA, just give an antibiotic, see what happens with the numbers. I don't want to necessarily do that if I don't have to, because I don't like hitting gut with antibiotics if we don't have to, because we will have to talk about this eventually. Gut microbiome will be an ingenious way to implement a change in your immune system. So if we want to go down that rabbit hole, improve gut microbiome, but you'll have to get a stool test, which is why I have the Genova boxes over here.
Got it.
So anyway, not yet. That's too deep of a rabbit hole, but it is a useful thing. But I might as well just give you this while we have it.
Yeah.
So I brought this out. This is the Genova stool test. It's a 3-day poop test.
Okay.
Nobody likes it, but I do believe that. I've seen good results with fixing the data, not mine. Good results with fixing the gut if there is an imbalance, whether it's zonulin that's too high or your Bacteroides to Proteus ratio is off, or you just have inflammatory markers, or you're not making enough short-chain fatty acids. I think that is a nice thing if it's covered by insurance. What kind of insurance do you have?
Blue Cross.
That's pretty decent. We'll keep that on the side, but we'll deploy that if we have to. But we still have so many levers that we can pull here. So, so if it is an elevated prostate, a PSA, if it is enlarged as diagnosed on an MRI, we'll see what the guy says. How often are you ejaculating in a month?
2 plus times a week.
Okay, so sometimes I think there is data. I've always thought that from before. There is data that shows a decreased ejaculation. Sometimes it enlarges the size initially,
Got it.
but that's not you. The bike seat is still there. With your sales, are you taking people out?
No.
No. What's your alcohol intake per?
1 a week.
It's not
2 a
even,
week, maybe.
unless that's a gallon. That's nothing much. So
Beer.
alcohol is down. You're not eating fast food. You're exercising more than the average person. You're meditating every morning an hour, you said,
Yeah.
unless it's on the bike. And then do you have any stressors? Certainly. If you look at the Ornish protocol,
not enough.
part of the Ornish protocol is group therapy. So therapy usually has to be sprinkled in. So wait, did you say not enough stressors?
Well, not enough to have an impact on me. Yeah. I mean,
That's very subjective.
true. You're right. I mean, a stressor to me might not be a stressor to you, or vice versa. But no, it's nothing that keeps him awake.
You are in sales. Are you the only primary breadwinner?
Yeah.
Number one. Number two, how many hours a week do you work?
I mean, 40 plus. I work at home though.
At home. Are you admin, or are you? I don't know how sales.
No, so I got 4 direct reports. They're the direct sales people. I'm their manager, let's call it.
Okay,
but
so you have
I'm in a great work environment, so I'm not feeling that.
You're not at the bottom level of the ladder as far as
No.
work. So the likelihood of having somebody step on you and articulate how aggressive you would be is lower, I guess.
Yeah. Yeah.
So the hierarchy above you is very forgiving.
For sure.
Okay.
Best work environment I've been in my career.
So work is good. Do you have a relative you're taking care of? I mean, caregiving is always tough.
No, my mom, she's in Florida on her own. She's in a great facility. She's independent living. She will move to assisted at some point, then memory care whenever that takes over. So no.
In-laws?
No, same with my Jen's dad. He's down in Florida. Same situation.
Kids from before?
My daughter's 27. She's independent on her own and
You're not worried about her?
No.
So we don't have any bullies at work. We don't have any bullies at home. Don't have any. You don't have any caregiving duties, somewhat.
No.
Okay, so you have the perfect life. So, well,
I mean, relatively speaking.
Yeah, relatively speaking,
I
compared to the average American. Average American doesn't have what you have.
Yeah.
Average American intentionally does not have what you have, and average American, usually males, die at 72.
Yeah.
So if you think about it, you have 13 years left. If you were an average American male.
So honestly, the way I look at it, and the only thing I lean on is, okay, what happened to my dad? Right, at 69,
okay, fair. Genetics.
We started recognizing his memory loss, and then it turned into dementia, and it went quickly, and he died at 78. So I look honestly.
Did you say 79? They noticed it, and he died at 78?
No, 69.
69. Then he died
at 78. So I look honestly at that as being like, okay, what's my worst case scenario? It could, beyond the prostate thing I'm dealing with, which is, I'm looking at the next 10 years, saying I'm all in on the next 10 years, assuming worst case that happened to me at 69.
All in as far as making changes, or all in as far as
everything?
Whatever you have to do.
Let's just assume my life is 10 years.
Yep. That's a.
I don't want to be a pessimist.
That's morose. Well, you're not pessimistic. That's a morose way to think about it. But sometimes that's the driver that keeps you engaged.
Exactly.
So I have to tell you that when my guys come in and I tell them, this is off, it's like I'll lose them in 3 months, and I'll have to say, hey, we have to meet again. But when you have the threat of death, and that's why sometimes we'll bring it in. This is not death. This is just an elevated prostate and an enlarged prostate, and your LDL is elevated. Yeah. I think those two can be manipulated. Although if you look at Western medicine, this theoretically cannot be manipulated, and that's why they call it active surveillance. We'll just watch him until it.
I don't know how I would reverse it. I mean, if you look at my trends, to your point on is it all of a sudden going to I notice something, unless it's glaring and obvious that I could turn it around, but.
Well, that's
or
what
will it
Ornish,
stabilize?
That's what Ornish had found. Ornish had found that prostate cancer in situ was reversed. I think it was within his data on the narrowing of arteries, Widowmaker included, was 3 months, 6 months, and then he extended it to 5 years, and they still, the guys that, it's a small subset, the folks that manifested that and maintained it, they're still making it. It's only a group of 20, but still, that something impactful happened to those folks, and it still continues to impact. I think the data on that same algorithm being applied to the prostate cancer in situ patients, that was a shorter study.
Got it.
But if we use that as our linchpin to say that's what we have to practice, I think that the data is positive, and you're already implementing a lot of the things, kind of, except for the nutrition plan. Mm-hmm. But in your case, I was going to try to sell you on adapting that. I'm not convinced that we should adapt that, because if I move, this is like a baby mobile.
Yeah.
And if I move the nutrition, the whole mobile will be offset, because you're really invested in your exercise. And as any cyclist will tell me, you mess around with the fuel system, even if it's not due to the fuel system being changed, you were concentrating on that's the variable. I don't want to do that anymore, because you're taking away my performance.
Yeah.
So
I'm sorry. In all of this with lipids, and I think you went through it, what about a heart scan? Would you ever recommend it?
As a matter of fact, yes, in fact, that's what got me on my journey to maintain.
Got it.
The reason I'm maintaining this, and I have 6 more months, is last July, before I took my group to Mount Whitney, I decided, I'll get it's called a CT angiogram.
Okay.
That's the only way to non-invasively get a value on narrowing amount. I got a CT angiogram. I don't have a problem with saying this because I already did a video on it and it's public, but I'm 69% on my Widowmaker.
Okay.
And I thought I was pretty decent as far as my health and my nutrition, but still, there's a variable that got through and gave me narrowing. Now the problem is I don't have a comparison. And most of the cardiologists will tell you, well, even though it was a low amount of radiation, there might be some error in that. The best is always going to be where they squirt you by bringing you in the hospital and give you dye, which inherently has some problems with it. But I think as a proxy, I do have a narrowing. I'm going to repeat it. I've been maintaining what I'm doing now, including Registrice, berberine, aggressive amounts of high-quality fish oil, and then a high-carb diet. I'm sorry, a low-carb diet.
Got it.
So I'm maintaining that until next 6 months, and on my self-experimentation will be I'll repeat the CTA at the same place. I've been watching my markers. Everything, I've been getting my LDLs down, my LDL-Cs down to 50s. The data, if we forget about the prostate at this point in time, we just look at the data as far as a heart attack. If we're going down that route, whether it's heart attack here or narrowing up here, like your dad in his memory, the data shows that if you lower your ApoB to 80 and you lower your LDL-C to, although I don't like LDL-C as you know, but if you lower your LDL-C to less than 70, you will stop further narrowing, and you change your diet.
Yeah.
If you lower your ApoB to 40 and if you lower your LDL-C to 50, there's potential that you can reverse the narrowing. Ornish didn't have that, but I've been trying to keep my LDLs 50, but it's not that hard, especially with athletes. And Registrice. I mean, I am cheating by doing Registrice, so I'm not sure, because I'm doing Registrice at maximum dose. I'm also doing a ketogenic diet, so I'm not sure which one is. I don't care, honestly.
Yeah, right.
All right, so as long as I do that and I implement more cardio, which I never liked, but maybe that was what gave me the narrowing. I don't know.
Well, that's the other piece, right?
What's that?
I mean, the hours of intensity, probably not good.
Well, I don't know. What do you mean?
I mean, I don't know. Marathon, I'm not doing. However, athletes have come back from these heart scans, and who knows, it's completely attributed, but with not great results from a narrowing perspective, and they attribute many times to the amount of intense exercise.
Got it. Are you talking about CAC, the calcium score, or are you talking about the CTA?
Oh, okay, so completely different.
Right. CTA is when you get dye, but you go through a CT scan, and the dye outlines the narrowing or the size, the caliber of the lumen.
Okay.
Versus, and that's expensive. Let's just face it.
Yeah.
I had to pay $500+ per month out of my pocket but it gave me the inspiration to make this change and maintain this change. I was actually going off the rails for Christmas, and my LDL-C went up to 80, which I said, no, bring it back down. Anyway, the CAC, coronary artery calcium scan, just checks calcium. So, and then by proxy, there was the MESA trial that looked at cholesterols and CACs and found that there was correlation if you have a high amount of calcium and a very high LDL-C, that there's a high possibility for heart attack. And if you had low calcium, pretty decent, but it didn't disqualify you. So regardless, the CACs are high in athletes. Some are high in athletes. I've seen that study. And the thinking is, I don't know that the data that I saw went forward to get a true, what does that elevated calcium count equal as far as narrowing of the lumen? And I saw it stop there. But the theory was that some athletes, even though they were very good at Olympian level, had, because of the output of pressure during the intensity, the theory was that that's what drove some of the calcium, but it was good calcium. Well, it could be
hard
considered
plaque, right, as opposed to soft.
Right. So there's a difference between calcium that's hard plaque and solid, and as what now is being thought of as a fix. The calcium is a fix to, or your patch up. The body tried to fix itself by throwing calcium in there, versus a soft plaque, which has a little bit of calcium, but you have this invisible narrowing of soft stuff that can break off very easily.
Right.
So that's the argument now, and I think Dave Feldman came out with a study just recently on what he called hyperresponders. I don't know if he termed it hyperresponders, but people that are on a low carbohydrate diet that just have massive amounts, 300. I have one patient that came to see me, or just dumped off her information. I think her LDL-C was 300, 200 to 300. That's life-threatening theoretically. Wow. But her CTA that she did in California, because it was paid for and funded by the Feldman Group, the CTA and the plane ticket was paid for. Her CTA initially, at the start of her study, his study was 0. So no
unrelated.
Totally open.
Wow.
But I did see the follow-up CTA, they did repeats in a year of maintaining the food. I'm not sure if they followed the food by questionnaires or if they were, it had to be questionnaires. You can't really house anybody for 12 months like that unless you have a $6 million grant. So a year later, her CTA did show the development of mild narrowing.
Wow.
So yet her LDL-Cs were still high, and all the other markers of inflammation were low. So I don't. Now that's only one person out of his whole subset. I don't remember how many he studied, but the argument is she's maintained that kind of low carbohydrate eating for, I think it was 4 years prior. So at that point in time, no problems. But between day 1 and 12 months later, there was a slight bump up in her narrowing. So it would be interesting to see that they have this information that's being released now that the opposite of Ornish is coming out. And I think you're going to find, like with the data out of Stanford and Gardner, it's not the diet. It's how, number one, your lifestyle, it's also the sustainability of the lifestyle. So whether it's, even if your genetics are studied and what do they call it, the SNPs are studied, whether you're insulin resistant or insulin sensitive, it's still, there should be a personalized approach to everyone. Yep. That's why I think you don't have to follow the Ornish to the T. In fact, maybe that's how we'll answer this, how do we fix you now? You don't have to follow the Ornish to the T, but we do have to move forward. And I love data. If you're thinking, if we wait until the second opinion out of Northwestern from the prostate guy, cool. Maintain, don't change too much stuff. If you wanted to see, before you see him, what your LDL part, if that 1800 is doing anything, which it probably isn't, it'd be interesting to see what the heck is causing 1800 from 1100, and I don't have an answer to that. However, yes, to have you get a scan, I would, but it's hard to get those things approved. If we do it properly, the guys that I like Chicago Cardiology in Schaumburg.
Don't they have lower radiation?
He does.
GE one?
Yeah, Carlos. Well, I don't know the machine that they use, but Carlos specifically lowers I think it's the DLP, that's the exposure to radiation. I like his numbers. And when he did mine, I think mine was 50 or 30. And when I looked at the DLP, I might be mispronouncing the acronym, but when I looked at the equivalents to the Feldman group, she was like 200 something times 2. That's a lot of radiation. So anyway, we're getting off track. The idea would be, number one, if we can find a reasonable place that can hopefully chase the insurance first and get it approved. Blue Cross Blue Shield, you might be able to do that.
Yep.
Number two, if we can find a guy or a tech that doesn't really crank up on the radiation, you can get a really nice picture if you turn up the radiation and you just
Of course.
zero down for years. But we don't have to, and he was immediate.
Wow.
And he got some pretty decent, my 3D CT scan of my vessels is pretty decent. So I like his technique. I don't know how he does it. I like the technique of what they, I'll give you a script. You can call Rita and you can see if they can pre-authorize it.
Okay.
It might need, though, have you ever seen a cardiologist?
No.
So sometimes the pre-authorization will ask me, send over the notes, and I can send over notes, but then they'll ask, where's the cardiologist's notes?
All right.
Because I think insurance companies will do the best they can to not pay for it.
Yeah,
because again, they charge $500 if you pay out of cash, but I think they charge insurance $1,000 plus.
Oh, wow. I got it.
So insurance doesn't want to do that. They'll rather have you pay for a $50 CT scan.
Yeah.
But the information from a CT scan doesn't necessarily tell you about narrowing. So if ultimately we got this thing down, I think that you're doing the right thing. I might entertain, before I let that go, I might entertain a possible infection. We just have to think about how to theoretically do the trial of the infection without destroying the gut too much.
Yep.
And I think that if we do entertain that, if your gut is good and your diet is regimented, you should be able to recover what we kill.
Got it.
So
Okay.
antibiotics, if we use antibiotics that are not Cipro, you can go with Bactrim. Bactrim's okay. Bactrim is sulfa. It's what we give women for UTIs.
Okay.
The problem is for a prostate infection, sometimes that capsule of prostate is really hard to penetrate because it protects semen and our DNA to foster the next generation. So you have to keep on hitting it with antibiotics for up to 3 weeks, FYI. So just think about it. We don't have to do it, but do the research because I know you will. And we can try that until your appointment and see if the PSA goes down.
Let me, I was just going to show you my PSA over time because the visual on the thing I was going to mention that came top of mind is, don't they say that the particle count and size on LDL is positively affected by lower carb?
Particle count and low carb. Well, the standard thinking is that particle LDL itself is related to saturated fats. And it always gets grouped into every fat.
Yep.
So I don't know that I've read anything about the specifics on the LDL divisions like particle count and then the divisions of the sizes in the particle, and then for that matter ApoB would be related to high or low carb. Well, let me take that back. The data now is showing that the cholesterol is an innocent bystander, which is I always thought, and the cholesterol is the fuel. The diabetes and or insulin resistance is the igniter of the fuel. If you have just the fuel and no igniter, I think you'll fare well. If you have the igniter and no fuel, I think you'll fare well. And this would be low fat, this will be low carb. Putting it together, which is some people will say, I'm low carb in the morning and I'm high carb at night.
But at the end of the day,
Your still overall signal is that you're triggering the fuel.
That's right.
So I don't know that the data is showing one practice or another is leaning into that, but I think I am in agreement that the higher the carbohydrate, the possibility of insulin resistance is there. Insulin resistance is the trigger to me.
Right.
The problem is it's hard to measure insulin. I do fasting insulins like I do with you.
Yeah.
Theoretically, it's not as accurate as a 3-hour glucose tolerance test.
Right.
But nobody's going to sit for 3 hours. I mean, this is a 3-day poop test, and nobody even does this. 3-hour glucose tolerance test where you have to drink this slime in before you go, and you go in fasting, and you get blood tests every hour, before, at the first hour, and the second hour.
I did that, but only for glucose level, not for
insulin.
insulin.
Yeah.
I have to use the rest of it.
Or the data that you just showed me of the PSA going higher. something in 2020, if you think about it, temporal relationship has to be there. Something in 2022 to 2024 had jacked you up.
Yeah.
So, what was it?
The only thing
the
that happened
calendar.
during that time frame was COVID that I know of.
Fair. So during
Nothing
that
in my lifestyle,
Yeah.
nothing. Yeah, I mean, there's nothing.
you don't remember anything in particular?
Nothing.
Did you go through unemployment for that
No.
COVID? No. Did you have a loss of something?
No.
Okay, so nothing jumps out of you as far as your memories as far as 2022 to 2024, but I'll give you a little bit of homework, is to think about the timeline. Just when you're meditating, go back to 2022, which was when we were coming out of COVID,
Yep.
and try to go through season by season and see if there was a problem. I can think of one. You weren't with your group,
What group?
the writing group. Were you?
Oh, true.
Probably virtually.
That's true.
There's something in community that can be
Yeah,
lost.
Right. Considering that's where a lot of that meditative state came from, even with other people, right?
So the possibility is there that we got that bump, but then we have to go down there's a lot of politics that have been happening, so I don't know if you react to a lot of that.
We don't watch the news.
Okay, that's pretty good.
For that reason.
Yeah. So anyway, that's your homework, and if you notice a little hiccup, then maybe we'll attack that. But
Yeah.
so going back to why you presented that, before I let this go, we'll get the CTA, see if we can get it paid for by insurance.
Okay, so you do recommend I go forward with it? Okay.
I recommend everybody that has
I
a
would
question
love
mark.
to. Yeah, I would love to do it.
But honestly, that's a self-experiment. 1800 is not that big of a deal. Your ApoB was pretty decent.
Yep.
Your LDL-C is really good.
Okay.
You're doing everything you should be doing. Your insulin levels and hemoglobin A1C is fantastic. So you have no igniter. You don't technically have, well, you have a little bit of fuel, but you don't have an igniter. So I think we're still okay.
Okay.
The question would be, before we let that go, are you following in Dad's footsteps? I don't know. I would say there's cheaper ways to do it. You can get a carotid Doppler and find narrowing that way. It doesn't necessarily reflect what the arteries here are doing. Or we just go for the gusto, and that's a pretty decent picture.
Okay.
So we'll do that if it's paid for. If it's not paid for, I might just do this. The only problem is getting somebody to do this. I can't find the hospitals that will do a fecal transplant for my folks that have IBS or anything like that. Can't find a hospital that will do carotid intima thickness. I can hardly find a place that will do cardio IQs, although I found Quest has been the best at doing the cardio IQs. I don't like LabCorp because they do an NM measurement. It's indirect. And cardio IQs have been the best. There's other places. Anyway. If it's paid for, we'll do it. But we should still hold this as this is important because of that. This is our project for 2024.
Without a doubt.
So I think that, what are we going to do with this? You think about this. Number one would be, I'm going to help you negate Dad's history and your LDL particle with a CTA, if it's paid for. If not, CIMT. Number two, consider, because you have a month before you see the downtown guy, if he maintains that visit, consider prostatitis.
Yep.
There'll be a prostatitis treatment.
Now, his response to that, where people reacting on antibiotics like, wow, doc, I feel better, is it could be that the antibiotic reduced the inflammation, not necessarily cured something that was going on.
Reduce the inflammation of a theoretical cancer?
Or just inflammation that's going on with the prostate, and it wasn't necessarily killing a bacteria or an infection.
That makes sense. I've seen the data come out with the rheumatology folks saying doxycycline helps. Why does it help? Is it because you have a subclinical Lyme issue, or is there an inherent anti-inflammatory effect of doxycycline? Not only on the killing effect of a bacteria, bad bacteria, in a joint, but also on human, whatever it is, metabolism or inflammation markers or a cascade of inflammation. that data is limited. So as far as just throwing Bactrim on for 3 weeks, is it giving you a decrease in inflammation? Maybe. But if it holds, say it gets your prostate down, just argument's sake, if we initiate that ASAP, you have your appointment with him on the 22nd.
Correct.
You'll be done before the 22nd. I would target right at the last day, you get a PSA. And if your PSA is back to normal, we'll still keep his appointment.
Of course.
And then you'll throw that in front of him and say, oh, what do you think about this? Don't reveal, I wouldn't reveal that just at the time of delivery.
Last
I would,
card, back pocket.
yeah. And by the way, before you leave, because if he says, no, we'll just treat you with antibiotic.
I've already done
Done. Yeah, done. But if he says, yeah, let's get a biopsy specifically in that area, that's fair, but maybe it'll be interesting. If the PSA drops. If the PSA doesn't drop, well, and plus it has to drop below 4. It has to drop to previous levels.
Correct.
2019 was, what was 2019's number?
It was 2 something.
2. So it would be nice. I think it would be a win. You can't get Bactrim to change prostate cancer in situ. I guess that's what he was saying, right?
Say it again, sorry.
You said that, what's his name again?
Schneider, Ted Schneider.
Schneider out of
University of Northwestern.
Northwestern.
Yeah.
So Schneider, the urologist out of Northwestern, had said or commented on the podcast that sometimes people will take an antibiotic and get inflammation decreased.
Yeah, and feel better.
And feel better.
Yeah.
But was he attributing that to a change in the dynamics of going to cancer or not? Or was he not even talking about that?
He was making the argument that treating just prostatitis using antibiotics is questionable if it's really there's a bacteria involved, or is it really, the inflammation piece.
Makes sense.
God, that raised the question though. He brought something up. I'll think of it. Go ahead.
Okay. So if we do the 3 weeks, again, I don't think that Bactrim is narrow spectrum. You can have a wide spectrum antibiotic like Augmentin or ceftriaxone injectable or Zithromax, kills everything, positive, negative, some encapsulated, and that's a nuke on the battlefield. Right. So you'll kill good guys and bad guys. Bactrim is narrow spectrum. It's gram negatives mostly. I think it can be used for MRSA in some cases, so it's gram positive. But it's very narrow spectrum, so you won't kill the whole playing field. You'll just drop a bomb on one side. And again, if we're worried about the gut, just to allay those fears, if you have a very decent gut microbiome, and you don't have to prove it with that, but if it is good, it should be repairable on its own after you stop the antibiotics if you maintain a good diet. Sometimes fermented foods will ensure that you'll seed the gut back. But you're very healthy. I wouldn't worry about the gut microbiome. The only reason I did this is to see if there's a weak link that we have to do or take care of. But so that's how I would play that. If you don't want to do the antibiotics, you might want to consider can we do an anti-inflammatory in natural form or an antibiotic in natural form? Second possibility is Bactrim. First possibility, Bactrim. Okay. Second possibility is an herbal, like quercetin.
Oh, it came to mind what I was thinking about.
Yeah.
So with Dr. Wu, when I got back the results from the MRI, he said we can do a biopsy right away. He said the other alternative is you can take whatever the med was to reduce BPH.
Oh, okay.
And if it works, then you probably don't have cancer.
True. Yeah, because cancer doesn't stop. Even if you throw, so tamsulosin, the alpha, so there are some receptors in every cell in your body, and the alpha is sometimes if you stimulate them the right way in the prostate, that's one of the receptors, it will reduce the size. And it's always going to be the biggest size, big size, especially if it comes on rapidly, is usually because the prostate is just inflamed. So right, if we throw antibiotics or if we throw tamsulosin on, should give us some kind of a change. If it does, then again, it's a win-win. The question is which road. So
I think the side effects were pretty bad for that stuff, though.
it's not too bad. So tamsulosin, you have to worry about blood pressure, although it's a terrible blood pressure medicine. It's just, if you have somebody who has high blood pressure and BPH, that's a great medicine to use. And then there's issues with DHT, or the conversion of testosterone to dihydrotestosterone. Are you worried about that, hair-wise or sex drive-wise?
No. I did side effect. I forget what it. Oh, breasts, growth of breasts.
Gynecomastia? It's not a common one, but again, if you follow your estrogen and testosterone, we would do a limited. It'd be cool to do a baseline test on.
I think we did that last time. Estrogen?
Estradiol.
Oh, I think you did that last time.
How long ago?
I'm
Estradiol.
going to have to look through it. A couple of years.
Level. Yeah, we want to repeat it before. If it's paid for, I would always like data. It'd be interesting to prove or disprove.
Yeah.
You don't have to if it's not paid for, but I think going back to the gynecomastia, low side effects. We have other things, and I'd probably compromise by giving you an entry-level amount if we're going down the road of prostate help. But prostate, the tamsulosin or finasteride versus antibiotics and Bactrim. Either way, so I don't know how long it takes for the alpha blocking to work.
Right.
I know that the antibiotics is 3 weeks.
Yeah.
So that might be something to consider. So timing, because we have to. It would be nice to get results from our experiment before you see Schneider. Because if he does want to do I have to pull you off of stuff. If he does want to do biopsies, then it would be wise to stop all medicines that I would do with our trial. So
I also have a colonoscopy at the end of March.
That should be okay.
Okay.
Yeah, piece of cake. Get that out of the way. You won't be going back for 10 years. Why?
Oh, it's due. 5 years. I had a couple polyps.
Hyperplastic polyps or just adenomatous?
They were fine. And when they.
Okay.
Yeah.
If it's every 5 years.
As opposed to 3, right?
Yeah. Well, depending. If you have hyperplastic polyps, you get it every 3 with a full colonoscopy. If you had a flexible sigmoid, every 3 to 5. If you just do the fecal occult testing, whether it's DNA or just heme or guaiac, it's like every 3. No, keep that. I don't think that has anything to do with it. So maintain it. You'll be cleared for super healthy by 60, healthier than the average 60-year-old. You just have to see how we're going to beat this or bring it down.
Yep.
So I do think that this is a reactionary thing.
Okay.
I actually think that the prostate's also reactionary. I just can't figure out what the trigger is. But you'll think about that. So our experiment will be that. You decide on Bactrim versus herbs versus alpha.
Alpha is the
Tamsulosin or finasteride.
Okay. And what are the herbs?
It would probably have to be an antibiotic herb. There have been some data showing if you manipulate selenium, if you use watermelon. What's the active ingredient in watermelon? I can't think of it at this point. There's I would go antibiotic herbs, quercetin, and I'm blanking on what I'm thinking about. Saw palmetto.
Oh, right. Yeah.
So an anti-inflammatory that seems to be focused on the prostate. And turmeric. So that will be the herbal way. I don't know if it would make a difference. Sometimes herbals are slower than prescriptions, but they have less side effects. Again, if we do the Bactrim trial, I don't think you're going to have any side effects. I don't think we're going to destroy too much. Just be a fast trial. If we do the tamsulosin or the alpha blocking, I guess that's a wrong term, but if we do the tamsulosin, that too, I don't know how long that will take to result in a shrinking, but when did you have the MRI done?
6 weeks ago.
Okay, so it's pretty fresh. I don't think he'll want another one unless he's very, very strict and he'll want you to get his MRI. Where'd you have the MRI done?
At, what's the hospital?
Sherman?
Yeah.
Okay. You know what sometimes helps is if you preload his thinking by sending the information to his nurse.
So after the podcast, I went into his site and it said inquiry, right? So I put my name and number in there and typed exactly what it was, which is, hey, here's my rising PSA, had an MRI, and I said, love to get an appointment, not knowing that it was, when I got the response back after I submitted it, this was more about talking to him about speaking engagements, etc. So I went ahead and called his office, got the appointment.
Wait a minute. He thought you were wanting to book him?
Well, that's what the portal appeared to be.
Oh.
Okay, so then the next day I went in, because that was at night, I went in and reached out and got an appointment. He then, in turn, responded to my initial input, right? And he said, what did the MRI show? And I gave him full detail. Here's the size of the prostate.
So he has it.
Yep, here's et cetera, et cetera. I didn't hear back because probably he saw that I had an appointment.
Okay, got it. Okay, interesting.
Yeah.
I guess the podcast is generating some traction for him. Well, he's probably a good doc anyway, but you booked it when? Because they're usually 3 months to 6 months out if they're that popular.
Well, so I booked it a week ago.
That's pretty decent.
Yeah,
so,
I was surprised.
Yeah, that usually doesn't happen, so maybe the traction didn't take place yet. The bottom line is you have an appointment, so so it's either medicines in the form of antibiotics, herbals in the form of start that now and maintain it probably forever regardless of the result, and then or the tamsulosin trials. So think about one of those three things, but I wouldn't change too much else. I think everything I've seen on the data that we did, which is metabolism panel, the lipid, fancy cardio IQ, vitamin D, FYI, should be improved.
Okay.
I think that helps. I don't think it'll change any of these two things, the LDL particle count or the PSA, but the vitamin D always seems to have this effect on, well, it's a weak link and it helps to improve everything. Just like the gut, those are rabbit holes, but for sure your number was like 30 something, so we want 70. FYI.
So I could just double my...
Yeah, that's easy. It'll go up. The rest of the numbers look fantastic. Insulin sensitive, B12, iron, folate were great. HDL, triglyceride HDL ratio is fantastic. Testosterone, as I mentioned, you're like a 30-year-old instead of a 60-year-old. So, and I just can't think of anything else that's wrong.
I think what improved was the DHEA and EPA from the last time I saw you.
That I didn't. Let me see. CBC, the CBC is still showing white blood cell count is slightly on the low side, but I wouldn't chase that.
My dad's was like that too.
And you don't practice intermittent fasting. Wait a minute, did I do DHEA?
Maybe you didn't.
I don't think I did. There's a sexual hormone binding globulin that's high.
Okay.
The SBHAG...
it's like 78 or something, right?
77.
Okay.
So that sometimes accounts for why the testosterone that's floating around there isn't deposited. Your Uber driver is locking the doors.
Okay.
But I think your free testosterone is still pretty decent, and your performance, I think, and muscle response and or cardiovascular response is still fantastic.
And recovery. Seems
recovery.
Yeah.
I wouldn't do anything with that. I'd just watch it. Sometimes you'll find SBHAG goes up with insulin resistance. You're by far not insulin. You're insulin sensitive. With this cheap insulin that I did, 2.9, that's fantastic. I think 2 or 3 is pretty decent. 2.9 is fantastic. I get some patients who are what I think metabolically challenged or insulin resistant, and that's 10 to 20 or higher.
On insulin?
Insulin levels.
Wow.
Yeah, if you're on insulin, well, you can't really test insulin if you're on insulin because it tests...
No, I'm sorry, insulin levels.
Yeah,
insulin
measuring
at 10.
Yeah, insulin levels. So 10, I can kind of make a decision if they're obese, overweight, or high blood pressure, that 10 is bad. 20, no question. Even if you have no risk factors, 20, I would attack.
Yeah.
And it just means implementing fasting, changing around the macronutrient count, or exercising. Okay. So sprinkling in a change. Yours is fantastic. So I can't find anything else. We'll have to see what your free cortisol looks like.
Yep.
As long as it's 0.3 or higher, then we know that you slept well and you subjectively continue to sleep well. Last night was the first night in a long time that I didn't have to wake up, but I chose a quarter bite of edible.
Those do wonders.
They do. The question is, does that supplant for a very good sleep cycle? What wearable device do you have, by the way?
Garmin.
Fenix or?
I don't even know what the model is.
Okay,
It's a
that's
newer
okay.
model. Oh, Forerunner.
Forerunner, nice.
Yeah, yeah.
So you can track sleep, although
Yeah.
let's see what the cortisol level shows. If the cortisol level is bad, I might want to see what your Garmin says as far as deep sleep and REM.
Okay.
But I'm assuming you don't fall asleep in the middle of the day, so it's probably see your pants is great as far as sleep.
Yeah, I mean, I fall asleep immediately when I lay down.
When you lay down.
Yeah.
But I think your lifestyle is fantastic. That's why I don't think that's going to be an issue. I definitely don't think that's going to be an issue. This is the lifestyle of a centenarian, American centenarian, and short of the food. The only American centenarians that we have are the Loma Linda ones, and they're all plant-based and Seventh-day Adventists. But your Seventh Day is going to be your bike. Your plant-based is different, again, because of what I call the fuel and igniter thing. So I don't think I would worry too much. I would maintain your lifestyle as is. I'd congratulate you. I would just say it would be a cool experiment to see if we can do one of these things.
Yeah.
I'm not too worried about this. This would be a cool experiment to also see what your baseline narrowing is, if there is any at all, especially with the exercise that you're doing. So one more thing, going back to me, I'm more of a muscle head, so I find that usually the resistance guys, I have a lot of guys that are resistance, and really they lift me and you over their heads, but they're metabolically challenged. So I'll find that their muscle growth is great, and their type 2 fibers are probably really great, but they're just insulin resistant, and if they're in their 20s, fine. But if you maintain that, I think you have to have a mix of cardiovascular fitness as well as resistance, which is what I changed my tone to from July of last year.
Grudgingly.
Yeah, and it's not fair because I now have a trigger that's making me do this.
Yeah.
As far as if I can reverse this, I'll probably still reverse it and continue this lifestyle until I can get my arteries, I hope, opened up to 50%. I don't have a problem with 60 going to 70 and 50% narrowing as long as I maintain it. But if I didn't have all this data,
you'd be down your last path, right?
No, I'd be dead.
Oh.
My LDL is like 130.
Okay.
Maybe but if I didn't do the ApoB or the LDL particle count or the CTA, going by standards, my cardiologist would say you're fine. And I think he has said I'm fine.
Yeah.
No offense to the cardiologist, but I don't fit the need for a PCSK9 inhibitor or a statin I can make an argument for. But if I continued down this pathway, 69% would eventually become 80%, which will eventually become 99%, and I wouldn't have known. So I think that your self-experimentation and my self-experimentation is getting us to a level where if we use this properly, we should be able to push past our whatever roadblocks are in our way.
It's nice we have data.
Yes, I think it is. Sometimes it's it drives you into obsession compulsion.
Yeah, of course.
But I think that we have to take the helm.
Yeah.
Because if we do the standard thing like you did, if you stood with your standard urologist, you probably have everything cut out or burned out. And I don't think we have to do that straight. So, if you did your standard LDL-C, we wouldn't have found the 1800.
Yeah, exactly.
So we would have just watched you. I don't think that the angio will show us anything bad. You'll probably, because you're 60, you'll probably have 30% narrowing certain places. But again, as long as that baseline is cool, as long as that's fixed, you're back to being. So I have to tell you, you got knocked off of my boring list, but that's okay because the fact that you have this kind of lifestyle, you'll get back on there, my 1%ers. So, and again, the 3 guys that are on my boring list are all cyclists, and I've now adapted because of you and my other 2 guys have adapted cycling. I don't have a Wahoo kicker yet, but eventually I will.
You'll get hooked. It gets to a point where you're like, I can't imagine cycling out of my life.
Yeah,
You know?
I think the community and the theories that are followed and just how good you feel, I think I understand it now.
And the lack of pounding in your body. I mean,
Right. It's different than marathoners or ultra marathoners. I have a lot of those guys who have now arthritic change.
Yeah.
Cycling, no. Maybe neck. I had one Ironman, or Iron Lady, and she had terrible neck issues from this.
Well, that's my weak link. I got 3 herniated discs.
I wouldn't worry about that.
Yeah, I've gotten beyond the initial blowout. That was years ago, 10, 12 years ago. So
again, if you think about that analogy as far as a herniated disc in the back, they're supposed to expand and contract, just like your tires are supposed to be able to take shock. So they will bulge out a lot. But if you tell somebody that knows how to cut that you have pain and they find the disc, what are they going to do?
Yeah.
So just I think the mechanics should be evaluated. Even if you're a weathered rider, I would get into somebody that knows riding as far as a physical therapist, but that'll be down the line. Don't worry about that. And you kind of beat it already.
Well, actually, you sent me to, God, what's his name? Asian guy, physical therapist.
Dr. Stu?
Yeah, he's awesome.
Yeah.
And I did that because I was having pain because I was started to run a bit. I did a couple 5Ks. And he helped me with so much stuff. That guy is awesome.
He's OCD with regards to watching alignment and movement. Yeah. Last time we did a talk together, he was on his 7th day of water-only fasting. And I don't know how he did it because he was probably the magnitude of the talk. He could see the energy.
Amazing.
But he's definitely dedicated. He knows his stuff. So hopefully you don't need him anymore.
Yeah, exactly.
Yeah.
Yeah.
All right.
He helped me a lot with,
Good.
Going forward, prevention, stretching, etc.
This is what we have to do. We develop the algorithm, we implement the algorithm, and when a speed bump comes up or weather changes, so to speak, we change the algorithm.
Yeah.
So, but the fact that you're invested so much makes it so much easier to just change the direction a little bit.
Right.
Yeah. So I wouldn't worry too much, but let me know what you think about those 3 options.
Okay. I'm leaning toward the antibiotic.
Okay. I don't think you're going to have a problem with it, but if we do, I will need a pharmacy.
It's the Walgreens in West Dundee.
Got it. Okay, I know it.
Yep.
I got it. I'll leave a message. You decide.
Okay.
If you want to pick it up. It should be pennies on the dollar, honestly.
Yeah. Okay.
And then we see. The one side effect with Bactrim is if you are a sunbather, you can burn faster. That's the only problem. But I don't think you're going to have that problem now.
Going on vacation, but not till the 14th of February.
To Southern?
Yeah. Caymans.
You gotta wear sunblock. Even if you're on the scuba, it has to be waterproofing.
Okay.
That's all. You should be okay. But wait.
I'll be done by then, right?
When is that?
12th of February.
12th of February. Yeah, we'll be done.
Yeah.
So perfect timing. And that too will also lower your PSA. Just the relaxation, inflammation. True. Yeah, no
It'd be
question.
nice to go into him with, hey, look what I did before I saw you. Knock on wood.
It'll be interesting to see what he says. I wouldn't be surprised if he, one way or another, if he gets biopsies or tissue is the issue, but sometimes when you can go by how the look is on an imaging test, that might be good enough.
You know what? If we have to do the biopsy, do it just to get the answers, right?
I think again, so those aren't too bad either. So if you haven't had it done, it's smaller than this, but you have to have a rectal.
Yep.
And then you hear tap, 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 and then you're done. Wow. Depending on the person, they use an ultrasound to kind of see where the thickness is, and they go into that area.
Okay.
It's almost like a thyroid. So a thyroid is the same thing. You get an ultrasonographer to do this, and they'll say, here it goes, and you'll feel something here, but they numb you up skin-wise.
Oh, got it.
Down here, you don't really need any numbing in the internals.
Right,
There's no nerve endings deep into the rectum.
Yeah.
And usually that's it. So it doesn't even hurt, theoretically.
Yeah.
But one way or another, don't change too much. So I don't think that do we have anything else that you had or Jen wanted to talk about?
No.
I think you're doing everything perfectly. I think this is just a temporary speed bump. And again, if you weren't doing all this stuff with self-experimentation, these 2 things would have popped up about 15 years ago. So the fact that you're doing the right thing and you're a boring guy, as far as not having that many medical diseases, I think everything's perfect. So
and how about this? If I'm going to do the antibiotic, should I
hold on to the box for now?
Okay.
But after the prostate is settled, I might, if you wanted to fine tune anything.
Yeah, I'd love to know.
That's a little. Yeah, I mean, you gotta work with poop, so most people get discouraged. But the gut microbiome is definitely the new kid on the block as far as what can be moved or manipulated to improve longevity and metabolism, for that matter. So Justin Sonnenberg out of Stanford and his work with my favorite scientist, Chris Gardner, is just pointing towards changing population changes with gut. But it's just, there's so many other things, and people are resistant to doing that. Again, I'm not sure if it's paid for. But if it is paid for, just like the CTA, more data, better.
Yep, I agree.
All right. Well, I think we're good.
Cool.
All right.
Appreciate your time.
Yeah.